Oh, hi guys. So today we have another psych study with me. I'm preparing for my step 3. Well, I don't have a date or anything, but I mean, I know it's going to come sometime mid this year. So I'm just doing like this and that. And I just thought to share on my channel so I can also review with you guys if you're interested. And today, let's talk about schizo family. Schizo. For the longest time, I didn't know what psychosis was. I would just to see psychotic this, psychotic that. I'm like, what is even psychosis? Like, what is psychosis? So for me, when I think about psychosis, I think of 3 things: hallucinations, I think of delusions, and then disorganized thoughts or speech in thinking. So they're going to be seeing things or hearing things that are not there, believing things that are not true, believing it very strongly, and then thinking weirdly or talking weirdly. So that's like, for me, the easiest way to think about it. So now let's talk about schizophrenia. So schizophrenia, we have 5 symptoms that can present or that actually present in the criteria. And these are 3 that we mentioned already, plus disorganized or catatonic behavior. So let me just run it through again. Hallucinations, delusions, disorganized speech, disorganized behavior, and flat affect or negative symptoms. So these are like flat affects, like no expressions. They're almost mute. Like, if I don't know, if somebody's baseline is like this and this is someone like who is hyperactive, talkative, like a mania, these guys are toned down. They don't care. They give that vibe of, I have this apathy towards this thing, I don't want to do this thing, and they're just, so that's negative symptoms of schizophrenia. And for us to diagnose schizophrenia, we need 2 or more of any of these 5. And one of these 2 or more must be either hallucinations, delusions, or disorganized speech, okay? And then something else that is also really important to know is the timelines. It has to have been there for 6 months plus, okay? This is very important because if it doesn't satisfy that timeline, then we actually cannot diagnose schizophrenia. We'll diagnose something else, right? So these guys also have this like functional decline, cognitive impairment. Like, if it's someone that was a student, they won't even attend classes anymore because they're so unkept. They don't really want to do school anymore, or they don't want to come out of their rooms because they feel like maybe something is after them. The government is spying on them. The cafeteria food is bad. It's there to poison them. Those kind of things. So yeah, so they're going to have this cognitive impairment and functional decline, social decline. And then something else that is worthy of note is that in adolescents, they usually have this prodromal phase. So before these full-blown symptoms of schizo would happen, there would be like maybe a college roommate or a friend that said they actually stopped going out much. They stopped going out. They didn't want to go out anymore. That kind of thing. There will be this social withdrawal. That something is actually changing, if you don't know what exactly it is. Then in children, or in pediatric cases of schizophrenia, you're going to see more of hallucinations than delusions. I think of it like children are more likely to hear or see things that are not there. Okay. And now remember that we talked about timeline. So if we have less than 6 months, but more than 1 month, we'll diagnose it as schizophreniform disorder. And then if it is less than a month, so we have a month, and then 1 month to 6 months, and then we have 6 months and above. So less than a month is brief psychotic disorder. Between 1 month to 6 months is schizophreniform, and then 6 months plus, we have schizophrenia. Hope that's clear. Something else that is super close to this family would be schizoaffective disorder. So we've kind of talked about this when we talked about MDD with psychotic features. This is one that they love to pit against it because the symptoms actually look the same. But in schizoaffective disorder, so these are people that they actually have these psychotic disorders because it's primarily a psychotic disorder. But they're actually going to also have mood disorders, either depression or mania. It's a primary psychotic disorder. First, that's the main thing. But then with the psychosis, so that's with the delusions, with the hallucinations, you're going to also see times where they have mood disorders. So maybe things like depression or mania, right? And the way you would know that this is primarily a psychotic disorder is that there are going to be times when they don't have any mood disorders, but you're going to see psychosis present. Unlike in MDD with psychotic features, where it's primarily a depressive episode, but with depression, you're going to see some psychotic symptoms. I hope that's clear. So find out what is the primary symptom, and that primary symptom is the one that in the absence of the other, is still going to stand alone, right? So if it is like schizoaffective disorder, there are going to be times there are going to be absence of mood disorders, but you still have psychotic disorders. You're still going to hear voices and things like that. So the next thing we're going to talk about is neurological tie-in with schizo. So if you do an MRI of someone who is schizophrenic, what are you going to see? So you're going to see loss of cortical tissue volume. So the cortex. So you're going to see, which is like the outer part of the brain, the one that has the sulci and the gyrus. So you're going to see loss of cortical tissue, and then with that loss would come ventricular enlargement. So your ventricles will be enlarged, right? So that's important to note. And then let's talk about antipsychotics. These are one of the biggest group of drugs in psych. I feel like antipsychotics and antidepressants are two of the largest groups. So today let's talk about antipsychotics. So we have two large subtypes, the first generation and the second generation. Okay, so the first generation now are also called the typical, and then the second generation are going to be called the atypical. And for the first generation, we have also two other classifications where we have the high potency ones, the ones that work so good even with the smallest of doses. Then we have the low potency. So the poster child drug for the high potency would be haloperidol, right? So there's also fluphenazine. And then for the low potency, you have your clopramazine. The other ones are over my head right now. I'm just going to put them in the subtitles so you can see what we have. And then we have our second generation antipsychotics. And this divide is very important because it also reflects in the kind of side effects that we are expecting to see. Okay, so now let's dive right into it. Let's talk about it more. For the antipsychotics, I'm going to be referencing my Ambos library a lot because they have this very amazing table, and I don't want to forget anything that's important. So we already talked about the high potency versus low potency. So the high potency drugs have a very strong dopamine 2 receptor antagonism. Now, first thing I should have said earlier that most antipsychotics are going to target your dopamine. So they're going to do some form of dopamine blockade, right? So the first generation high potency work very strongly on your D2. And now, because of that, the most important side effects you're going to see would be extrapyramidal side effects. So your dystonia, your tardive dyskinesia, your akathisia, and those ones, Parkinsonism. We're going to talk about that later on. However, it's very important that you should just know that this class is the most notorious for EPS side effects, right? Because remember, what causes Parkinson's disease, for example, it's because you do not have enough dopamine in that nigrostriatal pathway. So this treatment of schizo with your first generation is kind of inducing a low dopamine state in that pathway, and they're going to see movement disorders, right? Another thing that you can see would be hyperprolactinemia. Remember that dopamine is a prolactin inhibiting factor. Now, if you're blocking dopamine, you're blocking the effect, and prolactin is free to go as high as it wants to go. And the way they would ask you in questions, so you would see mostly sexual side effects. So prolactin will shut down your hypothalamic pituitary axis, your HPA axis, and then you're going to see things like low libido, amenorrhea in women, gynecomastia in men, galactorrhea, sexual dysfunction, in men. So that's also one thing that will kill you as a side effect. And there are other potential side effects like your neuroleptic malignant syndrome. We're going to talk about that when we talk about psych emergencies. Okay. Now, the second generation, we have clopramazine and terridazine. So for these ones, also remember that in addition to dopamine blockade, they also have anticholinergic and antihistamine blockade, and that antihistamine blockade is going to give us sedation. Okay, sedation, very, very important. And they love to throw in that anticholinergic thing, especially when it comes to older people, they dry them out and stuff. However, there's something that is very important for you to note, and that is that this class has some weird associations with eyes. So clopramazine will cause corneal deposit. Why the Theo one? I remember the T because it's retinitis pigmentosa. And in the second generation, quetiapine also causes cataracts, but we're going to get there. The second group would be your second generation, and these ones are notorious for your metabolic syndrome. Metabolic syndrome, like that's obesity, weight gain, new onset diabetes mellitus. They would like see that the waist circumference is getting bigger than it was before they initiated these drugs. And your examples are your clozapine, olanzapine, risperidone, quetiapine, that gang, lorazepam. Those are like your atypicals. And what makes them special would be that in addition to D2 blockade, which is lesser, they don't block D2 as much as first gens will block D2. They also block other receptors. They block D2, right? And then they also block 5-HT2A receptor. That's a serotonin receptor. And they block other receptors like your D3, your D4. So they do a lot of things. They also even have alpha-adrenergic blockade. They have your H1 histamine blockade as well. So because of that serotonin blockade, that serotonin receptor blockade, they are best used for your negative symptoms. They work well for positive and negative symptoms, unlike your typicals that work best for positive symptoms, while they worsen negative symptoms. All right. So this might be why it would be nicer to start patient on your second gen, because you want to tackle both effects at the same time. Right. And another thing you should notice that aripiprazole is a partial D2 agonist. We talked about metabolic side effects as some of the side effects that we see in second gen. Two drugs are most notorious for that, clozapine and olanzapine, right? And then what other side effects are important? Aripiprazole, which we just talked about as a partial agonist, is also implicated mostly for akathisia. Akathisia is that extrapyramidal symptom or side effects where they are too restless, they can't sit still, they can't stand still, they feel that urge to move that we treat with propranolol. So this is implicated. It has a higher risk for it. It also has a higher risk for impulse control problems. So they can't control their impulses, so they begin to gamble and things like that. And then ziprasidone is also implicated, has highest risk for QT prolongation, unlike others. And remember that any drug that can prolong your QT can cause torsade de pointes, which can also cause ventricular fibrillation, which is fatal. And another one, risperidone, is highly implicated for hyperprolactinemia. We talked about it as a side effect of antidopamine drugs. Risperidone has like a higher risk. Clozapine has a low risk for extrapyramidal symptoms. Clozapine also causes myocarditis. It lowers the risk of suicide. So clozapine, lithium, these two drugs lower the risk of suicide. So clozapine has tons of side effects. Also causes granulocytosis, so it makes them makes the people that are taking it more susceptible to infections. However, it's actually like a good drug. The only problem is the tons of side effects. I don't know if I've mentioned that it also causes myocarditis. So we save it for treatment-resistant schizo, especially when they have like high suicidal risk, because remember that it lowers suicide risk. Is there anyone that I've not mentioned? Clozapine also lowers seizure threshold. So another drug that lowers seizure threshold would be bupropion, an antidepressant, right? And then because of this metabolic side effect, something we can do is that we should always check their BMI, always check their fasting glucose, always check their waist circumference, check their lipids, check their BP, so that they do not develop hypertension, diabetes on you when you're managing them. So I think that's like a broad overview of your antipsychotics. Now, for patients who have schizophrenia, it's also important to involve their families in their care. Some psychotherapy, let them know what's going on. So this is non-pharmacological, but therapy that involves families so that they can understand how to support and manage these patients would also reduce risks of hospitalization, rehospitalization. There are also going to be situations where patients would require or prefer long-term injectables, or they're the best for those patients, especially patients that can't. The amount of cognitive impairment or functional decline that they have does not allow them, have the kind of schedule where they are able to take drugs every day, or they don't even see the reason for the treatment, right? So for those ones, you can start them on long-term injectables. They are usually given IM, and we have haloperidol, risperidone, long-term injectables. But before you do that, you have to make sure that they do tolerate the oral formulations. They must tolerate it, and you must make sure that you find out what therapeutic dosage is best for them orally before you convert to intramuscular. We already talked about resistant, and the resistant is when you've already tried two antipsychotics twice and the trial you failed. Remember, your clozapine is your guy. However, remember the side effects of clozapine. They love to test it, neutropenia or agranulocytosis. So you see someone who's having sore throat or some kind of infections. Remember, this is also what you can see in your antithyroid medications. And then myocarditis also reduces seizure threshold. So your tonic-clonic seizures as well, your myocarditis. So these are some of the things that you can see in clozapine. So I think that in general is that's a general overview. I know I said that QT prolongation for the second generation antipsychotics, ziprasidone is most commonly implicated, but your first generation antipsychotics can also cause long QT interval. Haloperidol has sulfur side effects. Flufenazine can cause problems with thermoregulation. So people who are taking it shouldn't be in extremes of cold or hot. So I really talk about sedation because of antihistamine blockade. Yeah, so that's in general. So now let's talk about this big thing called extrapyramidal symptoms that they love to test. So you're going to be giving a patient who is on some form of antipsychotic. Usually it's going to be a first generation, right? Remember that strong anti-D blockade, anti-D2. And the first one is acute dystonia. You can see sustained or repetitive movements of the head, of the neck. Toxicolis can be present. Oculogenic crisis also, when there's like this sustained upward movement of the eyes. This one is usually like the first. It's the most acute, so between hours to days. And what you do is that you should withdraw the offending agent, like, so whatever you are giving them, you should withdraw it. And then the pharmacotherapy would be three things: benztropine or antihistamine or diphenhydramine or benzodiazepine. So remember that other drugs that can actually cause this extrapyramidal symptoms without being your outright, that are not your outright antipsychotics. One drug that has been notorious for this is metoclopramide. I remember a few weeks ago we had a patient who was given metoclopramide for vomiting, and then she presented like the next day or 2 days or so, and yeah, she had dystonia, right? She was treated with benzo and she got better. So the other one is akathisia. They can't sit still. When you're in the hospital, you see them, you're talking to them, but they can't sit still. They can't stand. They just have this urge to move, strong urge to move, and it's like restlessness, right? Now what you do is that you give them propranolol, okay? And usually, like, whenever they ask you about any of these things, the best thing is always going to be to withdraw or taper, right? But if in that case, like maybe this is somebody that has tried a lot of antipsychotics and this is the one that is working, you might not want to be quick to withdraw. And then they give you all these pharmacotherapy options, then you pick them. Apart from propranolol, second line would be a benzo as well. And now for acute dystonia, this can actually happen internally. So they actually might have laryngeal spasms. And in that case, you remember they just have to intubate them so that it doesn't close and compromise their airway. So another one would be Parkinsonism. Parkinsonism is actually the same symptoms that you see in Parkinson's disease, but this is not Parkinson's disease. This is drug-induced. So you can't necessarily call it Parkinson's, right? So the rigidity, cogwheel rigidity, that thing with the face where they're like hypomimic, they don't have so much expressions, the bradykinesia, shuffling it, you can actually see all of these things. What you want to do for these people, benztropine can work. Benztropine, I don't know if I've mentioned, is an anticholinergic. And then something else that you can do is to give them a dopamine agonist like amantadine. Amantadine is actually a viral drug, but it's used for Parkinson's because it has dopamine agonist effect. And then the last one, this is the one that's going to take a while. So this is somebody that you've given antipsychotic for months, and then you've given them antipsychotics for a few months to years, and then you come and then you have these repetitive movements. It is different from dystonia. Dystonia is like contractions, sustained contractions, repetitive contractions, and you're going to see dystonia pretty early. But these guys, it's like the latest to appear. So some repetitive movements, like maybe chewing movements or lip smacking movements, they're doing something with their eyes. kind of looks like tic, but it's not, right? And you're, in this case, you already know that this is something that you started them on, like you know their drug history. So for these people, you want to switch them to maybe a second generation, because remember, a second generation, remember those ones are not super notorious for extrapyramidal side effects. And this special group of drugs called VMAT inhibitors, these are like vesicular monoamine transporter inhibitors. So these are the drugs that would inhibit the transporting of your catecholamines that have been put in the package in the vesicles for taking out of your presynaptic. I hope I'm just rambling. All right. So when you make your catecholamines or reuptake them, they're packaged in these vesicles, and these vesicles are now going to be exported or transported outside to the synapse for work. But your VMAT inhibitors would typically block that vesicular movement and decrease the amount of catecholamines in your synapse. Right, so they end in benazine. So your tetrabenazine, valbenazine, tetrabenazine. Another place where you're going to see these drugs being used would be in Tourette's syndrome. Okay, now let's talk about your psych emergencies. Neuroleptic malignant syndrome, which is a common side effect of your antipsychotics, your serotonin syndrome, and malignant hypothermia. So let's just make some associations and what are the specific differences that we should look out for. And then and tardive dyskinesia. I don't know how high yield this is, but if they ask what the pathophysiology is, it has to do with supersensitivity of the dopamine receptors because of chronic blockade. Also has to do with imbalance of D1, D2 effects. And then some fancy English that says a cytotoxic destruction of GABA neurons in the striatum. You must want to pick that, all right? And then now to our psych emergencies. Our 3 psych emergencies, usually we would have malignant hypothermia, neuroleptic malignant syndrome, and serotonin syndrome. So let's make some associations and find out what the differences are. NMS has a gradual onset, right? And usually, I know we tend to associate it with when we give antipsychotics, but also this can happen when we abruptly withdraw, right? Antipsychotics, antidopaminergics, are meant to be tapered off slowly, but when you abruptly withdraw them, right, after obviously being on them for a while, you might also precipitate NMS. And there are tons of symptoms that you see in NMS, okay? Tons of symptoms, like autonomic symptoms. These autonomic symptoms are because of dopaminergic blockade in your hypothalamus, right? So you're going to see things like fever. And then you're also going to see dopamine antagonism in your striatum. This is like pretty easy to remember, because remember that we always associate dopamine receptors with our striatum, nigrostriatal pathway. The same thing that happens in Parkinson's when we block it, right? So in this, you're going to obviously expect things that would affect the muscle. So tremors, diffuse lead pipe rigidity. I think this is one that they love to throw in as a buzzword, right? So if they give you that as a buzzword, obviously lucky you. But if they just describe like some stiffness, right, or some decreased movement that makes the muscles very stiff, so you might want to be thinking towards NMS. You remember we talked about autonomic instability, so vitals are going to be all over the place, up, down. You're going to also see some sweating, diaphoresis, and because of that muscle rigidity, you can also see muscle breakdown. And remember that when we have lots of myoglobin getting into the kidneys, it can cause renal failure, right? Because obviously myoglobin is toxic, nephrotoxic. And also, you're also going to see in the serum increased creatine kinase. Why? Because creatine kinase is found in muscle, right? So what you want to do for these people is that you want to stop. If the problem was because you were giving it, then you want to stop it. Then if it was because you withdrew abruptly, you want to restart, right? So depending on why. Another thing is supportive care. So hydration, cooling, right? Depending on how terrible it is, you might want to escalate to the ICU. You can also give benzos. Benzos have a way of calming down sympathetic overactivation, right? This is also why we give benzos in cocaine use disorder. And then if it is refractory, we can give dantrolene. Dantrolene you're going to see again in malignant hypothermia. So now let's talk about malignant hypothermia. So just like the name hypothermia, right? But in response to some volatile gases. So this is someone that has been exposed to some anesthetic agents. Usually, that's like the most common. So like your succinylcholine, inhalation gases, and usually this is inherited disorder. It's autosomal dominant. So there might be a family history given to you in the question if you're lucky. So the pathophysiology behind this is a mutation in your ryanodine receptor. And if you remember, your ryanodine receptor is a receptor that controls calcium release in your sarcoplasmic reticulum of your muscles, right? So this mutation would cause there to be more increase or more release than normal. And obviously, what does calcium do? Contraction, right? So it's going to cause some sustained muscle contraction. So just like in NMS, you can see hyperthermia because all that muscle contraction hit, right? You're also going to see your myoglobinuria, just like we talked about. You can see your creatine kinase increase as well. And because these muscles are breaking down, you can see lots of what I call it calcium, lots of kalemia, right? What's that called? Potassium. You can also see lots of phosphate being released from muscles into serum. Other things you can see fast breathing, tachycardia, tachypnea. So for this, just think of something that has to do with muscle contraction, sustained muscle contraction, and that is going to give you inhalational gases or anesthesia, right? So it's like a hypercontractile state. Now, contrast this with serotonin syndrome. Serotonin syndrome, obviously, has to do with loss of serotonin for whatever reason. Maybe because you give an SSRI or you give an SNRI, or because you combined two serotonergic agents without knowing. Like the one they love is like when they want to integrate linezolid, which is like an antibiotic, right? And you're giving this, and the person is on an SSRI already, or you didn't allow enough time between your SSRI and your MAO inhibitor, between your MAO inhibitor and your SSRI, right? Anything that just causes there to be increased serotonin. And you have a lot of other drugs that are not they're not screaming serotonin, right? Like your cough syrups, your dextromethorphan in cough syrup as well, right? So anything that is serotogenic, St. John's wort, which is like herb, So for these guys, how I like to separate them. So even though I might see autonomic dysfunction, which is also in NMS, right? So it might not necessarily help me, but always think of hyperkinesia, hyperreflexia, and clonus. You're not going to see hyperreflexia in any of these other two. You're not going to see clonus. Clonus is like movement like this, like literally like repetitive like that because of hyperreflexia. Most likely, like you can elicit it in the knee, elicit it in the ankle, right? Hyperkinesia, nausea, vomiting, diarrhea, because serotonin just has this thing with GI symptoms. So whenever I see those ones, so even though I might see autonomic dysregulation, I might see hyperthermia, it might not necessarily help me because I will also see these two in the other ones. How do we treat? You also want to withdraw the offending agent. You want to also do supportive care, cool when necessary, hydrate. Drug therapy, benzos are also one of the drugs that we give. A second line, or if necessary, we can also give cyproheptadine, right? So this is like one place that you're going to see this drug. And before we move away from psychosis, I also wanted to mention that you can actually see psychosis in Parkinson's disease patients. So just in case they bring this. So one, Parkinson's disease can cause psychosis, right? And then also the drugs that we use to treat Parkinson's disease, like your dopamine and precursors like your levodopa, your dopamine agonists like pramiprazole. Remember that the problem, for example, remember that when you're treating schizo, you want to block, when you're treating psychosis, you want to block dopamine. So anything that would increase dopamine can also predispose to psychosis. So what you can do for these guys is that you reduce the dose of the medication that they're already on, or you start them on a low potency or second generation antipsychotic, and it will usually help. So now let's move away from psychosis and talk about your eating disorders. For eating disorders, we have three prominent types: anorexia nervosa, bulimia. Is bulimia nervosa, right? And then binge eating disorder. So let's explore these three and what do we look out for us to diagnose. In anorexia, one thing you're going to see, like the way we think of anorexia, we think of someone who does not want to eat, and their reasons for not wanting to eat can be different things, but usually they have a warped body image, right? They have this preoccupation with weight gain. They don't want to gain weight. This might be just an adolescent female who is having that, or even someone who is in a career that needs them to be slim or prim or proper, like maybe some people, maybe runners or ballet or actresses, not that kind of thing, where their body is like, the body image is like a big thing, right? So you see these people, they're actually going to have these, like, you're seeing them and you're like, you're not fat, but they feel like they are, right? And because of that, they're not eating. So we have different subtypes. The ones that are restrictive, these ones would not eat like tons of things that they would restrict themselves from taking, right? They might skip meals or might be on this diet, like very restrictive diet. Some of them would be on very intense exercise or workout regimens. And then we have the purge type. So these are the ones that they would eat, but then they would engage in purging activities like inducing vomiting or taking laxatives. And this is like one of the reasons why we can confuse this with bulimia. Purging activities or purging habits are not only seen in bulimia, you can also see them in anorexia. However, the difference would be in the BMI. We cannot diagnose anorexia except if the BMI is less than 18.5. Okay, if it is 19, 20, 21, even if they are purging, even if they have restrictions, it's going to be bulimia, right? Now, what are the things, some of the medical things that we can see in bulimia? Because of that malnutrition, they can have a shutdown of their hypothalamic pituitary axis. So they might have a hypogonadotropic hypergonadism state. So low estrogen, this can lead to amenorrhea, can also lead to osteoporosis as well. And they might also have problems with skin, thin, dry, scaly skin, lanugo, like fine baby hair, that's how they like to put it. They might feel terribly cold as well, so they will wear these big sweaters. That's how they bring it to the question. But just look out for someone who is not eating or who is eating and purging because they really want to look a certain kind of way, or they don't like how they look, or they think they're gaining weight and their BMI is less than 18. Then what would make you hospitalize an anorexic patient? What would make you say you can't go home? So if they're already bradycardic, right? So they have like a pulse rate of 30-something%, they're hypotensive. If they already have like some arrhythmias already, because remember that you can also have electrolyte imbalance in anorexia, you want to hospitalize them. If their weight is less than 70% of expected, right? So for example, we are seeing someone that has a BMI of 14, they need to be in the hospital ASAP. If they're already having orthostasis, so that means like when they fall down, their BP gets down and they get dizzy. If they're having marked dehydration, if the electrolyte imbalances, you can see them. If they're hypothermic, like less than 35 degrees Celsius, you want to keep them in the hospital as well. If they're already having some organ compromise, like I've seen actually some signs of renal dysfunction, liver dysfunction, heart dysfunction, you want to keep them in the hospital as well. And in that case, obviously you want to really feed them, right? And even if it is through a nasogastric tube, you want to do that. I think we already mentioned when first line doesn't work, olanzapine is an option, right? And then what else is there to mention about anorexia? That is important. I think that's something I wanted to say, but it's escaped my mind. If I remember, I'm going to mention it. So now for bulimia is these people are eating and purging, right? So the difference between bulimia and anorexia is going to be in the BMI. Whereas the difference between bulimia and binge eating is going to be in the actions after. Okay. And yeah, I remembered what I wanted to say. I wanted to say that in anorexia, your thyroid hormones can be low, but you don't want to replace. Once they get better, thyroid hormones normalize. In bulimia now, so let's talk about it. So they eat and then they purge. Right? So they eat, the purge. They're not okay with it and the purge. But their BMI is not less than 18.5. It's higher. So they might not even be obese. They might just be normal weight. But if the BMI is not less than 18.5, then you can consider bulimia. Right? And then what is really high yield about bulimia, which you can also see in which can also see in the purging form of anorexia. So there are some things that you see when somebody is purging, right? Especially when they are doing it through vomiting. When there is purging, especially when the purging is through vomiting, that sustained increased intra-abdominal pressure can cause subconjunctival hemorrhage. That vomiting can also cause alkalosis, right? What kind of alkalosis? Remember that when you're vomiting, you're taking away your HCl, so alkalosis. Also, there's going to be fluid loss, right? So contraction alkalosis causes fluid loss. And then hypochloremic as well, because HCl, right? So that's hypochloremic contraction alkalosis. And in response to that, your RAS system is activated. Also, you can see this thing called dental calluses when they put their hand in their mouth to induce vomiting. You can also see hypersalivation, so that will lead to parotid hypertrophy, right? Something else you can see. Okay, if I remember, I would say it. I think it had to do with that vomiting thing, but yeah. Anyways, they can also be purging through laxative use, right? So that's also something that you should keep in mind. That volume contraction can also lead to orthostasis, can also lead to dizziness. And also, because of the hypokalemia, you can see things like cramps, muscle cramps here and there. Yes, I wanted to say about dental erosions as well. Did I say dental calluses? Please, that I don't know if I said that, but please, just calluses. What's this thing called? Knuckles, then dental erosions. Okay, because of all the reflux of the acid, right? So binge eating, these people have uncontrollable urge to eat. So they might not even be hungry, so they would eat, and they're ashamed of it. They're not happy about it. They will eat alone because they can't control that. But the difference is that they're not going to do anything to purge. There's not going to be any action after, just guilt, depression about it. So for the drug therapies for this eating disorders, I think we already mentioned olanzapine for anorexia. Fluoxetine, which is an SSRI, can also be used for, is actually the first line for bulimia, with obviously CBT and nutritional rehab as well. Okay, and then for binge eating, CBT as well, behavioral weight loss therapy. So especially for those that want to lose weight, those are that overeating is causing to gain weight. You want to help them with that. You also want to give them SSRIs if they want a pharmacotherapy, and then another drug, stimulants, can also induce weight gain and also helps people that have binge eating. So you can also give stimulants, they help. And then topiramate, which is an anti-epileptic drug. The stimulants I've seen tested would be lisdexamfetamine, right, for binge eating. Now, in this binge eating disorder, bulimia, anorexia, there's a common theme where they're not okay with how their body looks. Let's contrast this with body dysmorphic disorder. So in body dysmorphic disorder, this is going to be a patient, mostly females, but they can also bring males, who is not, these people are not okay with how they look. So there's something, that thing to you might not even be noticeable or might be mild, but they are super preoccupied. So maybe just a small papule. They would say they have this terrible acne. They're going to wear baseball caps. They're going to keep looking at themselves in the mirror. Like, see, that thing, just preoccupation that is disproportionate to what the thing is. Or the way they have, like, there's a question that I saw. The girl is not okay with the way her breasts look. Everything is wrong. Size, asymmetry, this, that, and she has other custom-made bras to try to correct that. So looking at the breast and it's okay, right? But it's actually causing them distress, right? So, and for these people, you don't want to tell them that, look, it's in your head. Nah, you never want to do that. So you want to approach them by checking, okay, do they have insight into this? And insight means, do they know that they're behaving this way? Do they know that this is not real, right? So you want to do that. And then the other thing you want to do is, please never ever tell them that it's in their head, or that their ideas are flawed or is imaginal or imagined. And then if you tell them that they actually look okay, they will not believe you, right? So you want to focus on what are the things that are triggering this, what kind of stressors are they having that is causing this, like what is actually, you want to get to the root of it, right? And then also don't encourage them to do any cosmetic anything. Obviously don't tell them that cosmetic will not change anything, but don't encourage them to do some invasive procedures and things like that. And then the drugs that can help are SSRIs, obviously, and CBT as well. So let's talk about some 5 illnesses or 5 things that look alike. So they call it somatoform disorders and related disorders. So the first thing is somatic symptom disorder. In somatic symptom disorder, so there is actually a symptom, one or more. This symptom is bothering this person. It's actually causing them distress at work, at home. They tell you that they have abdominal pain and it's severe. You might do your endoscopy, do your scans, check amylase, check everything. You might not see anything. It's actually bothering them. So there's at least one symptom, all right? Okay, and they are bothered or they're distressed by it. So that's a somatic symptom disorder. Contrast this with illness anxiety disorder, where they might not have a symptom, or even if they do have a symptom, that symptom is mild, but they are more or less preoccupied with the idea of having a big disease. Okay, so I like to think of like, okay, someone that has like maybe a mild headache, and it's like, oh, doctor, I'm worried I have cancer, and they are legit, like, really preoccupied. It's actually a strong thing they can't shake. Okay, so for somatic symptom, you don't want to tell someone that is somatic symptom disorder that they're distressed. You don't want to not validate their distress because they actually feel that distress. So for them, the key is to tell them that they can come see you regularly, right? They don't have to wait for new symptoms to come and see you. So another thing that they can clue you into somatic symptom would be that they've had this thing for quite a while and they've been to different places, they've seen different doctors, they've done different tests, and everything comes back normal. So these people are always okay to hear that they're fine, or that they are not that they are fine, but that the test results have ruled out serious medical things. So we want to reassure them, right? And they're actually happy to hear that. Don't refer them, don't encourage them to keep visiting doctors and keep looking for not cure now, but cause, right? So give them regular follow-ups, help them build a relationship with you, and then you guys can now tackle together what stressors might be precipitating or making this worse, right? Then if that symptom is not a somatic or physical symptom, if it is a neurological symptom that does not fit into your known neurological syndromes like stroke in this dermatome or something like that, or in this part of the body, that's going to be called conversion disorder or functional neurologic disorder, right? So somatic versus conversion. Somatic is a somatic symptom, while conversion is a neurologic symptom, right? But it's also bothering them. Even if you don't see it, even if the test come back negative, it bothers them, all right? Contrast this with factitious or malingering. Factitious and malingering, they are the ones that are legit producing these symptoms themselves. The other three are involuntary, right? But for these people, these are voluntary symptoms. So for factitious, they want to be sick or they want to make another person sick. They make another person sick, it becomes by proxy. If they just want to be sick for some reason, maybe to assume a sick role or to take care of somebody. So maybe that gives them some validation, or it's actually very common in people who have who have had some abuse in their childhood, some trauma, and they love to give you a health care worker who is obviously knows much about insulin, so she's injecting herself, or about laxative, so she's making herself poop, or she's infecting herself, she's making sores and infecting herself, or someone who lives with someone who has a chronic disease, or someone who lives with someone who has like diabetes and knows about her parents or her family's diabetic drugs, so she can cause herself hypoglycemia. So that's also one way that they can test it. For this insulin one, they would love to throw in some C-peptide here and there. If it's exogenous insulin, then you know that C-peptide should be low because it's not produced by the pancreas. If it is sulfonylurea use, your C-peptide should be high because sulfonylurea makes your pancreas produce insulin, right? If it is an insulinoma that is causing this hypoglycemia, you're also going to see insulin high and C-peptide high as well, right? So they just throw this to also integrate it with endocrine. However, in malingering, these people are doing it for a secondary gain. So maybe they want some opioid, or they want to sleep in the hospital because it's warm and they're homeless, or they want sick leave, or they want financial gain, or they want compensation, or they want housing. So there's going to be a gain, okay? Factitious is also really found, I don't know if I've said, in people who have a history of trauma. Somatic symptom disorder, increased risks in those that had abuse, trauma, those that had chronic illnesses growing up, or who lived or grew up with people that had chronic illnesses, like took care of people. About malingering, their histories are not the histories will not align. Even you as a doctor, it does not make sense. Like what you're saying and what should be if you have a problem here. Like, for example, if someone has a stroke in your MCA, you kind of should know which part of the body should be affected, right? So if they have a neuropathy of this, you should know. So their histories will not be consistent, right? They might cooperate for non-invasive tests, but they won't cooperate for invasive because they just came for something. They didn't come for you to stick a needle in them or to open them up, right? Or to spend money on big tests, right? And they're not happy to hear that they're okay because they don't want to be okay. They are here for something else. Okay, so that's the relationship between somatic disorder, conversion, illness, anxiety, malingering, and factitious disorder. So I hope this video was helpful in some form. I keep trying to read. It's not easy to read now because I don't have a deadline, and some days I'm super tired. Like I don't feel like. Well, some days I actually push myself and I win like today. So I'll keep putting this out. Maybe me and somebody else, or me or 5 other people might find this useful. And maybe in 5 years time, I can look back and see where I was at in January of 2024. Anyways, if this helped you, please, I would love to hear from you. It really, really encourages me. You don't know how much it encourages me. All right, I'm waiting for you guys, and I'll see you guys in the next cycle. We'll try to wrap cycle up in 1 week or 2 weeks time, so 2 episodes. Let's see how it goes. Thank you.